Welcome to the Lymphoma Research Foundation's update on chronic lymphocytic leukemia, small lymphocytic lymphoma webinar. I'm Kendall, and I'll be the moderator for today's call. During today's call, you will hear from an expert speaker, and you will have an opportunity to ask questions. If you have questions during today's presentation, you can ask them at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete the evaluation of this program and gain certification of attendance. If you are listening by phone, this link will be sent to your email at the end of the webinar. And now I am pleased to introduce Jesse Brown. Jesse Brown is the Associate Director of Patient Education at the Lymphoma Research Foundation. Welcome, Jesse.
Thank you. And thank you to each of you for taking the time to join us on today's update on chronic lymphocytic leukemia, small lymphocytic lymphoma webinar. We'd like to thank our sponsors of this webinar, Adaptive Biotechnologies and AstraZeneca. Access to expert disease information is so important, and we are thrilled to be able to bring you this educational program. Before I turn the program over to Dr. Ma, I want to share information with you on the Lymphoma Research Foundation. The Lymphoma Research Foundation is the nation's largest nonprofit dedicated exclusively to lymphoma. Our mission is to eradicate this disease through investment in the most promising lymphoma research and to serve those impacted by lymphoma through quality education and support opportunities. As we continue to make progress in advancing lymphoma research, we also want to ensure that you have access to the latest information about your disease. The Foundation provides comprehensive disease and treatment-specific resources, programs, and services, all of which are offered free of charge and have been reviewed by lymphoma experts. Most relevant to today's call, LRF offers a variety of lymphoma-specific resources, many of which you can access at the bottom of your screen if you're utilizing the web link, or via LRF's website at lymphoma.org if you're on the phone. The LRF helpline can answer your specific questions about lymphoma, as well as discuss relevant treatment options in clinical trials. We also offer the Lymphoma Support Network, which is a one-to-one peer support program for people with lymphoma and their caregivers. The Lymphoma Support Network connects patients and caregivers with volunteers who have similar experiences to help give others strength to meet the challenges they may have to face. We also offer a variety of publications that have been reviewed by lymphoma experts to ensure you have access to the latest lymphoma information. We have comprehensive books on understanding NHL, HL, and CLL, and the transplantation process. Our mobile app, Focus on Lymphoma, is an award-winning app that provides patients and caregivers access to comprehensive content, as well as unique tools to help manage your disease. I really hope you will take advantage of some of the great resources and services that the Lymphoma Research Foundation provides. If you have questions regarding what you've heard about today, or if you need information about relevant treatment options and supportive care resources, you can reach out to the Lymphoma Research Foundation through our website at lymphoma.org or by calling our helpline at 1-800-500-9976. We have a wonderful program planned for you today, and I'm honored to introduce you to Dr. Shuo Ma. Dr. Ma is a hematologist and medical oncologist at the Robert H. Lurie Comprehensive Cancer Center at Northwestern University, where she is also an associate professor of medicine. Her research focuses on chronic lymphocytic leukemia and novel treatment approaches. Thank you so much, Dr. Ma, for presenting today. I'll now turn the talk over to you.
All right, thank you, Jesse and Kendall. And good morning, everyone. Welcome to the program. So today we're going to talk about CLL and SLL on current treatments. Here's the program outline. So first, we're going to go over some basic information about CLL, and then we're going to focus on the current treatment options, comparing the previous standard of care of chemoimmunotherapy with the current new options of targeted therapies. And we'll talk about a number of randomized clinical trials comparing the old and the new standard for now. And then the last part of the talk will be talking about some exciting new development in the CLL treatment arena. So as you know, that CLL treatment has been really evolving over the last several decades. So we're having a lot of new development to share, new exciting new directions to share with you today. So just to start about CLL, for those who are new to the CLL diagnosis, some basic information here. So first of all, what is leukemia? Leukemia is a disease of the white blood cells when there are clonal expansion of abnormal white blood cells in the blood and in the bone marrow that shows us leukemia. So we know that bone marrow is a place where all of our blood production occurs. There are three main types of blood cells: the white blood cells, red blood cells, and platelets. So when there are leukemias, the leukemia can arise from any type of the different type of white blood cells. So you can see there are myeloid precursors and there are lymphoid precursors. So when they're making mature blood cells, you can see in the blood counts, the major white blood cell groups include neutrophils and lymphocytes, and there's some minor groups including monocytes, eosinophils, basophils. So CLL, the chronic lymphocytic leukemia, is a disease of the B lymphocytes. So this is a disease of a mature, what we call CD5 positive B lymphocytes that's accumulating in the blood, in the bone marrow, but also involving the lymphatic system. So what's making the lymphocytic leukemia different from other leukemia is that because the lymphocytes not only travel and grow in the blood and marrow system, but it also expand in the lymphatic system. So we're going to see presentations of lymphatic involvement as well. Another term for CLL is SLL, which is a small lymphocytic lymphoma. So the reason why that's called is because, exactly as I said, CLL can have lymphatic involvement, so people can have enlarged lymph nodes or enlarged liver and spleen. So those are the features of the lymphoma. So because it's a lymphocytic type of leukemia, it can have both leukemia and lymphoma type of features. These two diseases are really the same process. Biologically, they're really the same. It's just some patients present with a different way when they're initially diagnosed. So most patients with CLL initially were diagnosed because they have elevated white blood cells, which we can see the circulating leukemia cells in the blood. So that's more of a leukemia feature, but there are also patients who present with normal blood counts, so with enlarged lymph nodes, and the diagnosis were made on lymph node biopsy. So that's more like lymphoma. But it's really the same type of disease with different presentations, and most patients during the disease course will have both features. CLL SLL belongs to indolent non-Hodgkin's lymphoma. It accounts for about 20% of all B-cell lymphoma leukemias, but it's actually the most common form of leukemia in the Western society. It accounts for about a third of all leukemias. There are over 20,000 new cases diagnosed per year and over 150,000 patients in the United States. CLL is a disease that's occurring mostly in older patients. The median age at diagnosis is about 70 years. There are more male patients than female patients, and it's more common diagnosis among Caucasian patients and much less common among African Americans or Asian patients. There's really no clear environmental or occupational risk factors that's causing CLL. There are a small number of CLL patients who has a strong family history, may have a genetic predisposition for developing CLL, but the vast majority of CLL patients, the cause of that is unclear. But we do know that aging is definitely a major component that's contributing to the CLL occurrence. If you look at the age-adjusted incidence of CLL, the incidence really goes up with different age groups. So the higher the age, the more advanced the age, the higher the incidence of CLL. And if you look at the patient age distribution for all of our CLL patients, over 70% of patients are age 65 and above, and over 40% of patients are age 75 and above. So it's more of an older patient disease, but we do have some younger patients, but it's much rare. So the disease features of CLL, we talked about CLL being a leukemia that involves the blood and the bone marrow. So with time, most CLL patients will have increase in their white blood cell count, primarily the lymphocyte count in the blood, and also increasing involvement in the bone marrow. If the bone marrow is occupied by increasing amount of leukemia cells, at some point it's going to affect its production function for other normal blood cells. So So people can develop low red blood cells, which leads to anemia. They can have a drop in the platelet counts or other good white blood cells, such as neutrophils. So that's what's going on in the blood and marrow. And as the disease is progressing in the lymphatic system, CLL patients can, with time, develop gradually enlarging lymph nodes. And we have lymph nodes throughout the body. Some of them can be easily palpable on exams, such as in the neck, in the armpit, and in the groin area. But there are also lots of lymph nodes internally in the chest, in the abdomen, pelvis, which can only be visible on the CT scans. Some patients can also develop enlarged liver and spleen. Sometimes CLL, especially in patients who have more advanced CLL, because of the cytokine release, they can have what we call B symptoms, which include significant fatigue, unexplained weight loss, loss of appetite, chronic fever that's unrelated to infection, or significant night sweat. CLL can also cause some other complications. For example, it can cause some autoimmune destruction of the red blood cells, leading to the autoimmune hemolytic anemia. It can have autoimmune destruction of the platelet counts, leading to what we call autoimmune thrombocytopenia, or ITP. Now, this doesn't happen to all patients, but a certain number of patients may develop this autoimmune condition during their disease course. CLL patients are more prone to infections because of the immunocompromised state. So we do educate our patients to make sure they're up to date on all of their vaccinations to minimize the risk of infection. And also make sure they're doing cancer screening, age-appropriate cancer screening, because there's some increased risk of malignancies. Richter transformation is a very rare complication of CLL in which the low-grade lymphoma develop into a more aggressive or high-grade lymphoma, and the treatment will be very different from the conventional CLL treatment. There are a number of prognostic factors that we have learned over the years. The most commonly used ones were, number one, the FISH study, which is a study looking at certain chromosomes which are commonly occurring. The changes of those chromosomes are commonly occurring in CLL. So, for example, 13q abnormality, 11q, 17p, or 12, trisomy 12. So those are the chromosome abnormalities that can be found among the CLL cells. It does not happen in your normal tissue, but only in the leukemia cells. We know that some of those chromosome changes are indicating higher risk disease. So you can see the arrow pointing to 17p deletion being the most unfavorable, followed by 11q deletion. The 13q deletion is actually the most favorable. If patients only have 13q deletion, that's typically indicating a more indolent clinical course. The next important prognostic factor is the IGVH mutation study. So we know that about half of the patients has unmutated IGVH, which pertains to a relatively less favorable clinical course compared to the other half of CLL patients who have the mutated IGVH. And in recent years, there are also some newer prognostic factors worth learning. One of the important one is called TP53 mutation. This one has a very similar high risk compared to 17p deletion because they're really affecting the same important tumor suppressor gene called TP53. Another one is called complex karyotype. So patient who has multiple cytogenetic abnormalities in their chromosomes tends to have a higher risk. So these are all relative speaking because CLL in general is still a low-grade indolent, meaning slowly growing type of lymphoma or leukemia. So the high risk is relatively speaking to other CLL patients. So most of the CLL patients, when they were diagnosed, were actually diagnosed at early stage when the most common finding is just a high white blood cell count, but they're otherwise feeling fine. Their bone marrow function is not being affected. So most patient diagnosis does not require treatment. They can be safely monitored with periodic checking their blood counts and physical exams to see how the disease progresses. But for most patients, at some point, they will require treatment. So these are the common indications for treatment listed here. Number one is if patients are having evidence of progressive bone marrow failure, which means that when their bone marrow production function is going down, people will start to develop either progressive anemia or progressive drop in their platelet counts or neutrophil counts. So those are indications that the bone marrow function is being affected by the growing amount of CLL cells. Another thing, indication would be if patients are having gradually enlarging lymph nodes or enlarging spleen, liver, especially when those are becoming bulky or growing relatively fast. So that would be another indication to treat. Symptoms. I mentioned the B symptoms previously. So if patient has significant B symptoms, such as low-grade fever, night sweats, fatigue, unintentional weight loss. So that would be another indication to treat. But I do want to caution you that those symptoms often are not specific for CLL. There are many other conditions that can cause those symptoms. So it's important to discuss with your CLL physician to see if those are necessarily due to CLL or due to something else, because people can have fatigue from many other potential causes. So we don't want to treat CLL because, fatigue can be actually caused by a number of other reasons. And typically those constitutional symptoms do not occur until a patient has much more advanced CLL when they're actually having some other indication for treatment. Sometimes we treat CLL because their white blood cell counts are rising very rapidly, but just because the patient have high white cell count, that itself is not an indication for treatment. There's actually no absolute white blood cell count number that we use to judge when to start. Patient can have white blood cell count in over 100 or 200-300, that still does not necessarily indicate treatment. So we're going to focus mainly for today's talk on the CLL treatment evolution. It's quite amazing to see how the CLL treatment has really evolved over the last several decades. So the first several decades from the 1960s to the 1990s is more as the entire oncology world is learning about chemotherapy. So we're also testing different types of chemotherapies in CLL. Initially, we have the alkylating agents, which are somewhat effective. And then the pure analogs came out, which include the fludarabine that many people are familiar with, that seem to be even more effective chemo compared to the previous one. And then in the 1990s, it's a combination of chemotherapies. In the 2000s is when Rituxan first came along. So Rituxan we're going to talk about is one of the most important immunotherapy that first came about. So we have learned that when you're adding immunotherapy to the chemotherapy backbone, you can really improve the overall response and the duration of the response. But since the 2014, really in the past 5-6 years, things have really developed at a much more accelerated rate. So now we're looking into a new era of oral targeted therapy. So we're kind of we're finding really this daily or once a day or twice a day medication that's working great and it's very well tolerated. So in a lot of cases, I'm going to show you some data to show that they may be even more effective than the conventional chemotherapy. So we're really going into a new era, and we'll be talking about the 3 different classes of targeted therapies: BTK inhibitors, PI3 kinase inhibitors, and the BCL2 inhibitors. So first, starting with the conventional chemoimmunotherapy. So this is, before the targeted therapy era. This was the previous standard of care for CLL. So among the chemotherapies which were listed on the left, we talked about primarily the alkylating agents. The most commonly used ones were bendamustine, also cyclophosphamide, chlorambucil. And then the second class of chemo is the pure analogs. The most commonly used one is the fludarabine. On the right are the immunotherapies. So the immunotherapies are monoclonal antibodies that's targeting a certain specific antigen, typically a antigen that's expressed on the surface of the leukemia cells. So when those antibodies are binding to that specific antigen, they're able to label those leukemia cells, and the immune system would then be able to come in to destroy those leukemia cells. So that's how the immunotherapy works. There are two types of antigen that we can target. One is called anti-CD20 antibodies, so it's targeting a B cell marker. And the most commonly used antibodies are the Rituxan or rituximab, which has been combined with a number of different treatments. And then in recent years, a newer form of anti-CD20 antibody called obinutuzumab or Gazyva has been incorporated more into the more modern regimens. There's another antibody called Campath or alemtuzumab. It has been a very effective immunotherapy, but it does have some potential side effects. But because the manufacturer has pulled the product from the market, so this is not really being used that much, but it had been playing a very important role prior to 5 years ago. So these are the chemoimmunotherapy, and if you can see the effectiveness of the different chemotherapy, so C stands for just the chlorambucil, F stands for fludarabine. So when we're combining these two chemotherapies, you can see that it's working better, both in terms of overall response rate and the complete response rate. But when you're combining the R, which is the Rituxan immunotherapy, so now we're talking about immunochemotherapy. The combination of immuno and chemotherapy are really improving the overall response rate and the complete response. So the FCR, there has been a number of very important large phase 3 randomized clinical trials demonstrating that, first of all, adding Rituxan, the immunotherapy, is better than the chemotherapy alone. So FCR has become the new standard. And then there are a number of other immunochemotherapy combinations that have been tested. So the most commonly used ones were the FCR for younger patients, so younger fit patients who can tolerate FCR. And then the next most popular for fit patients are bendamustine rituximab combination. And then for more older patients or patient who has a lot of comorbid conditions, we'll be using something called G-chlorambucil or the obinutuzumab, the newer immunotherapy combining with the oral chemotherapy. So these three regimens have been really tested in clinical trials, establishing that they're very effective, and the effectiveness are really the most effective with FCR, and the BR is the second most effective, and then the chlorambucil-based regimen is less effective. But the reason why we're choosing the less effective regimen is because the FCR does have a lot of toxicity. In fact, most CLL patients, because of the age group, would not be a good candidate for FCR because of its toxicity. So we often will be either using bendamustine rituximab or the chlorambucil-based regimen prior to the targeted therapy coming along. So then really over the past decade, there has been a lot of very exciting new clinical trials establishing that oral targeted therapies are becoming the new standard for CLL treatment. So there are two large classes of oral targeted therapies. One class falls into what's called B cell receptor pathway inhibitors. So that includes two subgroups. So it can be an inhibitor of the BTK enzyme or the inhibitor of PI3 kinase enzyme. And under each category, there are multiple products already being FDA approved or close to getting FDA approval. For example, along the BTK inhibitors, which is the most commonly used oral target therapy in the B cell receptor inhibitor pathway, it includes the ibrutinib, acalabrutinib. So these two products have already received FDA approval for CLL treatment. Zanubrutinib is a newcomer. It has not yet gotten FDA approval for CLL, but it is approved for some other lymphomas. And then the second category is the PI3 kinase inhibitor, which include adalasib or duvelisib. So those are the two oral PI3 kinase inhibitor that's FDA approved for CLL. The second big category of oral targeted therapy is called BCL2 inhibitor. So the product now is called venetoclax. which is a very important oral targeted therapy that works with a different mechanism. So let's look at the first category, the B-cell receptor signaling pathway. You can block this pathway either by blocking the BTK enzyme or PI3 kinase enzyme. So here's the pathway. You can see that this is looking at part of the leukemia cells. On the surface, there are a lot of proteins. One of the important proteins is called BCR, or B-cell receptor. So this is a protein that's very important messenger that really helps to transmit the signal from the environment the leukemia cells are living in. The environment the leukemia cells are living in, we call it microenvironment. So the microenvironment sends a survival signal, proliferation signal to feed into the leukemia cells. And those signals are transmitted through this B-cell receptor and then through a number of enzymes to transmit the signal inside the cells. So there are several important enzymes in this pathway that could be targeted using oral targeted therapy. For example, the SYK, or the BTK, or PI3K. So all of those enzymes are important messengers along this pathway. By blocking one of those enzymes, you can block the signaling for the B-cell receptor pathway. So what happens when you're blocking this pathway is that not only does it block the proliferation of the leukemia cells, but it also impacts the trafficking. So those leukemia cells, which were previously hiding in the bone marrow and the lymph nodes and the spleen, are now being pushed out into the bloodstream. So what we usually see is that when patients are starting treatment, you can see on the left, patients were having large lymph nodes or enlarged spleen. Once they start treatment, usually fairly quickly, within a matter of a few weeks, they can notice a pretty rapid shrinking of their lymph nodes and rapid shrinking of their spleen. And that's because those leukemia cells are leaving those places and coming out to the blood, where they're no longer able to receive those feeding signals, and those cells will gradually die away. As a result of that, when patients are starting treatment, when you're looking at the peripheral blood, white blood cells, looking on the left, the graph shows you before the treatment, patients' white blood cells are going up with time. Their hemoglobin platelets may be going down with time because of the leukemia progression. The graph on the right is showing that once they start the B-cell receptor pathway inhibitor, you can see that their white blood cell counts can really go up. Actually, about 70% of patients who are starting on things like ibrutinib will have an increase in their white blood cell count because those cells are trafficking out of those lymph nodes and spleen and coming out to the blood. So you can see increase in their white blood cell counts at the beginning of the treatment, which may peak around a month or so during the treatment, and then after that, the white blood cell count will gradually go down. So eventually, it's going to go below the pre-treatment level, and for some patients, they may normalize. There are other patients, it may not completely normalize, but they may maintain at a relatively low level. As the treatments are ongoing, you can see that the hemoglobin and the platelet counts often will improve with treatment because their bone marrow function is improving. So this is a fairly unique feature of the B-cell receptor pathway inhibitors, because conventionally with chemotherapy, we expect to see the white cell count go down as soon as you start treatment. So when we're seeing white cell count going up, we worry, is this not responding? But it's actually, in this case, it's a sign of response. So it's very common to see a transient increase in the white blood cells. So here, again, are the three BTK inhibitors. We're going to focus on BTK inhibitors and not spend too much time on the PI3 kinase inhibitors because I want to, since we have limited amount of time, I want to focus our talk on the frontline treatment for patients who have CLL who are receiving the treatment for the first time. So in the frontline treatment, the BTK inhibitors has a much more important role, at least for now. The PI3 kinase inhibitors are more used in relapse setting at this point. So the three BTK inhibitors, ibrutinib, or Imbruvica is the brand name, is the first one that's initially approved in 2014. This is the one that has really the longest history of clinical trial data. So we have learned a lot about how BTK inhibitor works, the effectiveness, as well as the potential side effects. The next two, the acalabrutinib or Calquence, and then the zanubrutinib or Brukinsa, these are what we call the second generation BTK inhibitors. So these are designed to be more specific for targeting the BTK enzyme and having less off-target effect in the hope that it may help to reduce some of the side effects. And then there are also newer BTK inhibitors that are currently being studied in clinical trials trying to overcome resistance. So the first two, the ibrutinib and the acalabrutinib, are currently FDA-approved treatment for CLL, both in the frontline and then in the relapse setting. So I'm gonna show you some clinical trial data for ibrutinib just as an example. The other BTK inhibitors are also looks like as effective. So ibrutinib, this is a study, one of the earlier studies looking at patients who are being treated with ibrutinib, the 420 milligrams once a day. So again, this is an oral medication, so you take at home. Once a day oral medication, and patient will continue the treatment for as long as it's working and as long as they're tolerating. So this is a long-term continuous treatment. So with this treatment, we can see that the response rate is very high, is in the close to 90% range. The TN stands for treatment naive. So these are the patients who are receiving ibrutinib as a first-line treatment. And then the RR stands for relapse refractory patients. These are the patients who had received prior treatment, other treatments, and now have been relapsed disease. So for both groups, you can see that the response rate are close to 90% overall response rate. The green bar is showing the complete response. So complete response is relatively low. Most patients have partial response, meaning that there's still some detectable disease, even though the disease burden is dramatically reduced, but there's still some small amount of residual disease. But despite this small amount of residual disease, patients actually do very well for a very long time. So this is what we call Kaplan-Meier curve, where you can look at how patients do over time. If patient relapse, with more patients relapse, the curve will start to drop. So the more to the right, the better, meaning that the treatment remains effective for a longer time. So for people who have relapsed CLL, you can see that the drug is very effective for most patients, with the median progression-free survival has not been reached yet as a 36-month mark. But for frontline treatment of CLL, you can see that very, very few patients actually relapse when they're receiving ibrutinib as a frontline treatment. So despite having still some residual disease, patient actually can do very well, having disease very well controlled for years. And now we actually have long-term follow-up data, 5 years, 7 years out. Still, the majority of the patients on treatment are still doing great. So I wouldn't go into, there are many clinical trials actually have been done on ibrutinib or on acalabrutinib. So we don't have enough time to go to the detailed clinical trial data, but just to give you kind of a general sense of how BTK inhibitor works. So for ibrutinib, it's once a day dosing, oral medication you take at home. For acalabrutinib, it's twice a day dosing. And then again, you continue this treatment. This is a continuous long-term treatment until progression or until intolerance. Ibrutinib or acalabrutinib can be used either by itself or combined with the anti-CD monoclonal antibodies such as the obinutuzumab or rituximab. So all of those indications are FDA-approved indications, either alone or in combination. The benefit of this treatment is that it's generally well tolerated, has a very high response rate, even though most of the response are partial response, but people do have very long duration of response. Patients do great over quite a long time through the long-term follow-up data. The potential side effects, I would say in general, most patients do tolerate the treatment very well. However, there are some potential side effects we do need to watch out for, and mainly that early on, there could be some mild gastrointestinal side effects, such as nausea, heartburn, diarrhea, but those tend to get better resolved after a few weeks or a few months of treatment. There are some ongoing potential side effects we do need to monitor. One is the bleeding risk. It's a small bleeding risk, but it's definitely notable. So we do educate patients to make sure they notify us if they're planning to have any surgery or biopsy, which in those cases we need to hold the medication for a few days before and after the procedure. Hypertension, patient can have about a quarter of the patient may notice some increase in their blood pressure reading. So some of the patients may require additional increased doses of their hypertensive medication or adding new medication to control their blood pressure. And then cardiac arrhythmia, in particular atrial fibrillation. This is something that we do recognize as something unique for the BTK inhibitors. So we do need to screen patients for their baseline cardiac risk to see if they're appropriate for the treatment, and sometimes we may choose second generation if we're concerned about their cardiac risk. Infection, low blood counts, those are the things that we do need to monitor throughout the treatment. And then some patients may have some mild muscle ache or joint ache. But for the most part, BTK inhibitors is fairly well tolerated. It's a long-term treatment. The second important class of oral targeted therapy is the BCL2 inhibitor, which is the venetoclax. So what is BCL2? BCL2 is a protein that is important in protecting the cancer cells from cell death. I show you in this graph a big rock sitting at the edge of a cliff. So interestingly, we know that CLL cells are primed to go through apoptosis or programmed cell death. But at the last step, they're stopped by this increased amount of this protective protein called BCL2. So there's an overexpression of this protective protein, BCL2, in CLL cells. And when you're blocking the BCL2 protein by using venetoclax, you're removing the last stop, so the big rock can actually go down the cell death pathway. Because of that, actually, venetoclax is a very effective treatment for CLL. It can actually induce a very rapid death in those leukemia cells. So I showed you that with the previous oral inhibitor, the ibrutinib, for example, you see increase in the white blood cells when you're starting treatment. With venetoclax, it's actually the opposite. Actually, you can see a very rapid drop in the white blood cells. So this is just show you once patients take one dose of venetoclax, if you monitor their blood counts, you can see a very rapid drop in the white blood counts. Sometimes within several hours, within a few days, you can see a fairly significant drop. And this is an indication of how rapidly cell killing can happen. And so it's a good thing for treating leukemia point of view, but it is something that can also be a potential risk. So the risk is called tumor lysis syndrome because whenever you're killing off leukemia cells or cancer cells, the dead cells can release waste products into the bloodstream, and sometimes when the cell killing occurs too quickly, your body wouldn't have enough time to get rid of those waste products. So there could be accumulation of those, and that can cause electrolyte shifts. And when we see that, it's called tumor lysis syndrome. So tumor lysis syndrome is something that can occur in any cancer treatment, but in particular in a very effective cancer treatment that kills off leukemia cells rapidly, such as venetoclax. So with venetoclax, we do need to monitor for tumor lysis very closely, especially when we're starting treatment. Going back. If you're choosing venetoclax treatment, you have to understand that this is a treatment that at the beginning of the treatment, you need a lot of very close monitoring, including potentially multiple blood draws within a 24-hour period of any new doses. And then the dose has to be gradually built up over a 5-week period because we don't want to give you a standard dose and causing too rapid of tumor killing. We want to give you a small dose and then over each week to gradually increase the dose to allow this tumor killing to happen more gradually. So tumor lysis syndrome is one of the major risks, but it's definitely manageable with close monitoring by your treating doctors. This is something that we can definitely manage. So this is a very effective treatment. There has been a number of clinical trials using either venetoclax by itself or in combination with the immunotherapy, such as rituximab or obinutuzumab. So we do know that by combining with immunotherapy, it seems to work better than just the venetoclax alone. Just to show you one example of venetoclax plus rituximab in patients who had relapsed refractory CLL, you can see that the overall response rate is 86%. And most remarkably, the complete response rate is over 50%. So most of the patients were able to actually achieve a complete remission. Now, I want to introduce you a new concept here. So we know that usually when we're looking at how effective a drug treatment is, we use the term partial response or complete remission. So partial response means that there's significant reduction in the disease burden, but there's still some detectable disease at the end of the treatment or while you're on treatment. Complete response means that at the end of the treatment or during the treatment, there's no detectable disease by CT scans or exams. There's no detectable disease in the bone marrow under the microscope. So when you're fitting those criteria, that's called complete response. But in recent years, now we're setting a higher bar even for the response, a higher standard, which is called minimal residual disease. So in this, we're using a special technique to detect a very tiny amount of residual disease that's not otherwise notable under the microscope. So in this case, we can detect as little as, even if there's one leukemia cells among every 10,000 cells, we're able to detect that. So it's a very high sensitivity detection. So if a patient has no detectable disease with this very special test, then they're called UMRD or undetectable MRD, or you can say MRD negative. So that's a much higher standard of response. It means that there's, even below the if there's no disease at our best detection technology, then this is a much deeper response. So 61% of patients treated with venetoclax plus rituximab were able to achieve this very deep response with undetectable minimal residual disease. So which is very remarkable. It's almost unseen in all of the prior CLL treatment history. So for patients who had undetectable MRD, they tend to predict a very long remission. So you can see that here's the duration of response. The green curve are for patients who had undetectable MRD with a complete response. And you can see at the 16 months, which is a 5-year mark, very few patients. So close to 90% patients are still remaining in remission. So very few patients relapse. So this is a very important message here, is that we do know that the deeper the response, the longer the response tends to last for this treatment. And because this treatment is able to achieve such a deep response, we can actually stop treatment. So this is not a continuous treatment. This is a treatment you can treat for a certain period, and then once you achieve a deep response, you can actually stop treatment, and patient can still remain in remission for a number of years before chance of relapse. So just to summarize what we learned about the venetoclax or BCL2 inhibitor, is the once daily dosing. It does require a 5-week dose ramp up and very close to tumor lysis monitoring. We typically combine that with anti-CD20 monoclonal antibody, such as rituximab or obinutuzumab. It is a limited duration treatment. Currently, the FDA approval for venetoclax plus Gazyva or obinutuzumab is for 12-month treatment for frontline CLL treatment. And then for relapse refractory setting, FDA approved venetoclax plus rituximab for a total of 24 months treatment. So this is different from the BTK inhibitor, which is a continuous therapy. So the advance of this treatment is that it can give you deep response, and patient can potentially have durable response off treatment. And the other thing we learned from clinical trials is that if patients do relapse several years down the line, they could be retreated with a venetoclax-based therapy and still can potentially have another response. The main side effect is tumor lysis syndrome, early on during the treatment, so it does require very close monitoring, can cause some mild gastrointestinal side effects, infection risk, low blood counts, so all of those need to be monitored. So the next question is, how do we actually compare the target therapy with conventional chemoimmunotherapy? Because that's really, when the target therapy first came along, that's really the biggest question is, we know that previously we used chemoimmunotherapy as a standard, but now with a newer treatment, how does it compare to the previous standard? So over the past number of years, there has been actually an amazing number of randomized large phase 3 clinical trials enrolling hundreds of patients to each trial, trying to address this question. We don't have time to actually go into all of this studies, but I just put in this table here to show you a few of the important studies. For example, the top one, the ECOG 1912 study, compared for younger patients, younger fit patients, FCR versus ibrutinib plus rituximab. So the patients are randomized to one of the two arms, and then they're being observed to see how they do over the long term. And then the next study is for older patients, comparing bendamustine rituximab as a chemoimmunotherapy versus ibrutinib with or without rituximab. And then there are a number of studies comparing chlorambucil plus obinutuzumab combination in older patients with comorbidities. So you can see there are 3 clinical trials comparing this regimen to different types of target therapy, ibrutinib plus obinutuzumab, venetoclax plus obinutuzumab, or acalabrutinib with or without obinutuzumab. For the sake of time, I wouldn't go into the details, but just to show you a quick one, the FCR versus ibrutinib rituximab treatment, you can see that the red line is the ibrutinib-based regimen. The dotted line is through the conventional chemoimmunotherapy. So both in terms of the progression-free survival and the overall survival, the targeted therapy actually are doing better. So even compared to the most effective immunochemotherapy, the targeted therapy really are superior. There's one exception is that for people who have IGBH mutated CLL, they seem to do relatively similarly. The difference is not that big. So if we're nowadays considering immunochemotherapy, probably the IGBH mutated patients is the only group who will still consider it. But chemo is no better compared to targeted therapy. For the interest of time, I wouldn't go into the details of the study for venetoclax, but this is a study with venetoclax combined with the rituximab. Again, very high response rate, over 90%, and very high complete response rate with over 50% of patients achieving a MRD undetectable state. And it's much superior compared to the conventional treatment of bendamustine rituximab. Okay, so skipping the details of the study, just to show you that based on all of the trials that we mentioned, basically the bottom line is that targeted therapies seem to outperform conventional immunochemotherapy in virtually all of the studies for all CLL patients combined. The only exception is that for IGBH mutated patients, they seem to be relatively similar, but definitely chemoimmunotherapy seem to be inferior in most of the other situations. So that's why there has been really a shift in the standard of care over the last several years in terms of choosing more of targeted therapies for CLL treatment in the front line. So in 2020, we're having a number of choices. Conventional immunochemotherapy is playing less of a role now, especially in the COVID era where we're concerned about the risk of infection. So it's mainly the discussion primarily focusing on whether to choose the BTK inhibitors or the BCL2 inhibitors plus the monoclonal antibody. Again, the BTK inhibitor is a continuous treatment, and then the BCL2 inhibitors are limited duration treatment. So it's really a personalized decision as to what's the best treatment for you. It's a discussion between the patient and the treating physicians. So quickly, I want to touch on some of the very exciting future directions. there are next generation targeted therapies, including novel BTK inhibitors, which are trying to overcome potential resistance to the first or second generation BTK inhibitors. There are novel PI3 kinase inhibitors. There are novel BCL2 inhibitors as well. So next generation is in the pipeline. And then there's also a discussion about what about if we combine the two classes of targeted therapy? So combining BTK inhibitors with BCL2 inhibitor plus an anti-CD20 antibody, or combining a PI3 kinase inhibitor with this combination. So because there has been data showing that when you combine the two classes of targeted therapies, there does seem to be an increased chance of getting into a very deep response and potentially a higher rate of undetectable MRD. And then lastly, very exciting, the CAR-T, which is a novel cellular immunotherapy. So briefly touch on CAR-T. So CAR-T is using your body's own immune cells called T cells. So we're harvesting your own T cells because these are really the most robust immune cells that can potentially be educated to become cancer-fighting cells. So we collect patients' T cells. We do some express a new protein on the surface of T cells. So now they will be able to recognize the CLL cells and able to mount a very robust immune attack on those CLL cells. There has been a number of studies ongoing. This is not yet FDA approved, so this is still experimental, but the early data looks very exciting. Even for CLL patients who has failed all of the standard treatments, we can still see a very high response rate, and some of the response are very durable. So when people were able to achieve a deep response after CAR-T, after 24 months, there has been no relapse. So this is a potentially very exciting salvage therapy in the future. We do have a number of exciting clinical trials ongoing for patients who are living in the Chicago area. At Northwestern, we have the frontline treatment comparing combined target therapy with the ibrutinib-based therapy, so the large NCI-sponsored studies. And then there are also a number of clinical trials for relapsed refractory CLL using the second-generation BTK inhibitor, PI3 kinase inhibitor, or second-generation BCL2 inhibitor. We also do have a CAR-T clinical trial for relapsed refractory CLL. So really the future is very bright for CLL patients with a lot of exciting treatment in the pipeline, but even the current standard of care, the targeted therapies are looking very effective and well tolerated. All right, thank you, and now we're open for questions.
Great, thank you so much, Dr. Ma. Just before we move forward, I just wanted to double check, are you okay if we go about 5 to 10 minutes over just to get to a few more questions?
That's fine, yeah.
Okay, great. So we already have our first question in, and the question is, can you talk about COVID and CLL? Specifically, what have you seen for patients both on watch and wait and undergoing treatment? And should CLL patients get the vaccine when it becomes available?
Mm-hmm. Yes, this is the elephant in the room, right?
Yeah.
Yeah, so COVID obviously right now is really occupying everyone's mind. It's really affecting our life in many ways. But in particular for CLL patients, it's quite concerning because CLL patients are considered at high risk for COVID-related complications. So I do educate my patients to be extremely careful about trying to do all of the standard precautions, social distancing, wearing masks, washing hands, hand hygiene, to help to prevent COVID infection. If everybody in the society does the same, that really help to reduce the spreading of the COVID. In terms of what we know about how patients do if they do get infected with COVID, there's really not a lot of information available yet. There was a small study early on, very early on, in the first 2-3 months, where a number of centers are pulling their data together, including our center as well, to look at how the CLL patients pan out when they did get infected. It did show a quite grim picture with a fairly high rate of severe complications, and including mortality as well. However, we have to keep in mind that at that time, the only patient who had confirmed COVID were those who had severe enough symptoms to have to be admitted to the hospital, because back then, we didn't have enough testing kits to test asymptomatic or mild symptom patients. If they did not need to be admitted, they were not tested. So this is not a very accurate, I wouldn't say that would be representative of how CLL patients would do necessarily. And then over the past number of months, we have definitely seen more numbers of CLL patients. I would say from my personal experience, the vast majority of my patients were able to pull through okay. Some of them did have a few weeks and not feeling well. Some of them did require some hospital stay, but the vast majority of them were able to pull it through. But still, consider yourself high risk and do all of the precautions you can. In terms of vaccine, so the vaccine, I'm sure many of you have read the exciting news recently about the new COVID vaccine that has two of the large vaccine studies have reported very exciting data showing 94% or 95% effectiveness for the COVID vaccine. So it does seem to be fairly effective, much better than what we're expecting to see. And those vaccines sounds like they were able to produce it in a matter of several months to be able to supply the country. So I would imagine as the vaccines are being, of course, we have to wait for FDA approval. Once they're approved, it will be distributed. We don't know how they're going to allocate the vaccine first. And I would imagine the higher risk patient probably will have a higher priority of getting the vaccine. I don't think there's any vaccine study specifically in immunocompromised patients yet. At least there's no data out yet, because now it's all kind of rushing to do on the large general population. But once we do have the vaccine, we will need to look at what type of vaccine, whether it's a live virus or non-live virus, whether it's appropriate for our CLL patients, because we generally do not recommend any live virus vaccine. So we have to wait to see which one comes through.
Thank you so much, Dr. Ma, for speaking on that. I know it's a topic, like you said, on everyone's mind. And our next question is, over 2 years ago, I was treated with BR for SLL and have been asymptomatic since then. Is it advisable to get an MRD test to see if cancer is returning?
No, we do not use MRD to monitor the disease because we know CLL is a disease that we cannot yet cure. So if you search hard enough, you probably will find some MRD, especially if you have already been a few years after the treatment. So MRD is still relatively a research concept. It's more to guide us in like venetoclax treatment, for example, to see whether it's a good time to stop treatment. But I would not use MRD to monitor disease. The routine blood counts and the exams will be sufficient.
And our next question is, after disease progression on venetoclax, what treatment options are available?
So all of the treatment options we discussed are available. So, if we're treated with venetoclax and the disease relapse, if it's after several years, you could consider to be retreated with the same regimen. Or you could switch to a BTK inhibitor type of treatment. So chemotherapy, we haven't really, nowadays we're really not using that much anymore, but that remains a potential option. And then, of course, consider the clinical trials.
Thank you. Our next question is, do you know if there's a way to freeze your T cells if you are in watch and wait? They would want to do it before they get any treatment if possible.
That's an interesting concept. I don't think there's a way to do that yet outside of if there's any research program, clinical trials to specifically look at that. It's not a standard yet. But we haven't really so far had much problem collecting T cells for the CAR T, if that's what you're thinking about, for patients who had been previously treated.
Great, thanks so much. Our next question is, what symptoms or side effects should I look out for after completing treatment that would indicate relapse?
It will be the same as how you're monitoring the CLL from the very beginning. So your doctor will be watching your blood counts, do the exam to look for lymph nodes and spleen liver changes, and then you'll be watching for those B symptoms we mentioned, like unexplained fever, night sweats, significant fatigue or weight loss.
Great, thank you so much. And we have a couple questions that came in terms of people just wanting to clarify again the SLL, CLL, and someone asked, can you explain how SLL differs from CLL in terms of selection of treatment?
In terms of treatment, there's no difference, actually, because they're biologically related same disease. Some patients, were diagnosed with SLL because their blood counts were normal. Their diagnosis were made based on lymph node biopsy, but it's really the same disease. So the treatment is exactly the same.
Great, thank you. Another question, does exercise have any benefits to maintaining baseline CLL?
What I tell my patient is that it's very important to maintain a good general health. So from all aspects, from your immune system aspect and from your ability to potentially tolerate any treatment. So it's important to actually maintain a good general physical health, including exercise regularly.
Thank you. Our next question is, can you explain if TLS is more of a concern with SLL and what is done to prevent?
So TLS is not specific for any disease or any particular treatment. So any cancer treatment has a potential risk of TLS or tumor lysis syndrome, but usually you don't notice it if the treatment works in more gradual fashion. But it's more notable when you have a treatment that works very quickly, such as venetoclax.
Our next question is, are there any guidelines to treat patients with CAR T option at this time in the COVID era?
For CAR T?
Yeah, any specific precautions or guidelines because of COVID?
Oh, I see. Okay, yeah. Obviously, CAR T treatment does involve some, immunomodulating treatment. So it might, at least for the short term, increase the risk of an immunocompromised state. But a lot of times people who are needing a CAR T are when their disease are progressing, that they have to get treatment. So you have to talk with your doctor to see what's weighing the risk and benefit of any treatment, not just CAR T, in the COVID era, to try to balance out the benefit of the treatment and the risk on the immune system.
And I think we have time for a couple more questions. This question is, what would be considered an effective low dose of ibrutinib?
Well, the standard dose of ibrutinib is the one that has been studied in all of the clinical trials. The low dose, there is no tested low dose. Sometimes your doctor may reduce the dose because you're taking some other medication that's interacting, or sometimes because of side effects. If it's because of side effects, we don't really know how well the low dose works. There's no clinical trial data to give you exactly how well it works. So we would not recommend a low dose ibrutinib treatment unless if it's necessary because of the things I mentioned, because there's not enough data to know how well it works.
Thank you. And our last question for the day is, we got a few more questions on MRD, and I know you clarified that a little bit, but we had one more that asked, can you clarify when MRD status is used with treatment and what a negative status means for immunocompromised status?
MRD has nothing to do with immune system. It's more a measurement of CLL, like how much residual CLL we can detect. So we don't have to use MRD for any treatment for CLL. For example, there's no point of doing MRD when you're on the BTK inhibitor with ibrutinib or acalabrutinib, because there's always going to be some MRD, but it does not matter. It does not really matter in terms of how long the treatment can remain effective for that class of treatment. It does matter when you're being treated with venetoclax or with immunochemotherapy, because at some point you're stopping treatment. So if you're able to get into a deep response, then likely that period of off treatment remaining in remission will be longer if you have a deep response before the stopping treatment.
Thanks so much for clarifying that. And I'd also like to thank you, Dr. Ma, for joining us today on this really comprehensive talk. We had a lot of patients on the call today, and I know they all appreciated your time. So LRF and all of patients online really appreciate it, and we thank you for joining us today.
You're very welcome, and it's a pleasure, and I also appreciate the LRF work to support our patients.
Perfect. Thanks so much. And thank everyone on the call, too, for joining us today, and we hope you found the information both informative and also hopeful. We'd also like to thank our sponsors again for making this program possible, Adaptive Biotechnologies and AstraZeneca. Please remember, if you have any additional questions or you'd like to be connected with someone who has been impacted by lymphoma, you can reach out to the LRF helpline at 800-500-9976. Also, at the conclusion of this program, you'll receive an email prompting you to complete a program evaluation. I ask that you please take a few moments to complete this, as they are very important for helping us to ensure we deliver the most useful and meaningful programming to you. And with that, I'd like to thank you all again for joining us, and have a wonderful day.